splenic pathology. Hence, you must also ask about any episode of fever, like high-grade fever or intermittent fever, plus any previous disease which is related to the vascular system, and loss of weight, loss of appetite, for example, chronic myeloid leukemia, blood disorders, lymphatic leukemia. In all these conditions, there is a splenomegaly. So you have to keep that in your mind also, that she may be suffering from malaria, she may be suffering from any disease of the blood system, and after that you will start the examination, and in the examination you will see the vital signs, you will see the anemia, you will see for lymphadenopathy, you will see for pudendina. So all those things are there. So we only concentrate on the abdominal examination. So first of all, on inspection you can see that there is umbilicus is central and the abdomen is scaphoid, except for some bulge in the epigastric region or slightly on the left hypochondrium also. And there is a scar of previous surgery on the right side, which was cholecystectomy, which was done about 4 years back. And she has multiple linea gravidarum. She has multiple pregnancies, and there is normal respiration. There is no visible peristalsis, no visible pulsation, no other scar from these two other than these two scars. Then you start the examination by doing a palpation, and on palpation you start from the right iliac fossa because the pathology is on the left side. There is no guarding, there is no tenderness, there is no local temperature raised. सांस लीजिए, liver appears to be normal. The scar is okay, except some hypertrophic scar here. Now then you go to the left iliac fossa, and from there you slightly ascend upwards and you reach the swelling, and you find that there is firm swelling which is striking your fingers, and it is almost oval in shape. It is going like this, and up to the here up to the costal margin, and here also up to the costal margin. And on the surface, it is firm to hard in consistency. It is non-tender, as you can see, she is not wincing, and it is irregular in shape. I cannot see any notches which are typical of a splenic swelling. So, and I can slightly insinuate my finger below the costal margin, which is again the swelling of the spleen. Now, before we decide whether it is a splenic swelling or some other swelling, we would like to examine the patient in the classical splenic position. मेरी तरफ कवर लीजिए, इधर आ जाओ, इधर आ जाओ. Having a splenic enlargement, you have to tilt the patient on the right side, and then you support the arm, and you start the palpation from the left iliac fossa and gradually ascend up towards the mass. Now I can feel the mass, and you will ask her to take a deep breath. सांस लीजिए. There is distension of the abdomen, but this is going up, but it's not going forward. If it goes forward, that means it is attached to the diaphragm, and hence it will go towards the medial side. But it is not happening like this. It is just up and down movement. सांस लीजिए. There is up and down movement of the swelling. ढीला छोड़िए. And now we will try to go above the swelling. Now you see my finger is inside the costal margin. So that means if the spleen is enlarged, my finger will not get insinuated into the costal margin. So this demonstrates that this swelling, although it is appearing like a spleen and it is in the same area as the spleen, it is not a splenic swelling, because otherwise my finger will not be insinuated into this. So now this is not a splenic swelling. You can further confirm it by doing a percussion, which we will do now. Now, there is a resonance. There is resonance. There is resonance. There is resonance. There is resonance. Now it is dull. So this is the costal margin, and this is there is a 2 centimeter gap between the swelling and the costal margin. So if it was a splenic swelling, this gap would not be there. There will be no resonance because there is colon here, and that is why it is giving a sound of resonance. So this is how you confirm that this is a non-splenic swelling. Now, if it is not a spleen, what it can be? So that is the question. So since it is firm, hard at places, it appears to be a swelling. There are 4 structures which are present here. One is the stomach, second is the colon, third is the pancreas, and then part of the liver, other than the spleen. So if it was liver, then it will be continuous with the liver dullness. So it is not continuous with the liver dullness. There is then stomach, no bleeding per rectum. So 3 things are from the history eliminated. Very unlikely to be arising from the liver, very unlikely to be arising from the stomach, very unlikely to be arising from the colon. So one structure which is not identified as yet is the pancreas. So if pancreas is generally retroperitoneal structure, it generally does not present anteriorly to present in the anterior abdominal wall. But if there is a pathology like a solid mass or a cystic mass or a tumor, benign or malignant, then it can present in the epigastric region like this case. So from the process of exclusion, it appears that it is a. Now the pancreatic swelling can be 2 types. It can be a pseudopancreatic swelling or it can be a true pancreatic swelling. So pseudopancreatic swelling will be cystic and it will not have an epithelial lining. But the true pancreatic swelling will be a swelling which will be arising from the body of the pancreas. Since it is more feeling like a hard structure at many places, and of course there is some cystic component also, so it to me appears as a case of true pancreatic swelling. It can be malignancy or benign, so that has to be confirmed by investigations. So with this clinical presentation, we have tried to demonstrate 2 things: that all swellings which are present in the left hypochondrium are not spleen. Secondly, there are 4 structures in this particular area and any of them may present as a mass. It can present as a mass of the liver, left lobe, or it can present as a mass of the stomach, carcinoma stomach, or it can splenic flexure of the colon. So these, but since there are no symptoms related to that, so we can say on clinical examination that it is not arising from any of these 3 structures. What is not been answered is pancreatic pathology. So with this, we will try to investigate the patient. Of course, routine investigations followed by at least a CT scan and an ultrasound. Of course, ultrasound is not a very good investigation for pancreas because stomach sits in front of it and hence gas is there and you cannot delineate the deeper structures. So CT scan is the ideal investigation for this, and we have sent for that investigation. Once the report is available, we'll discuss it. Thank you very much.